publicly thank Jason for the terrific job he's done in organizing this. Jason, can you flip slides as I go through them? Let's start with the topic we're talking about, which is about rheumatoid arthritis biologics and their potential efficacy in osteoarthritis, with evidence to be reviewed and biology to be reviewed, so that we can get a sense of whether, in the context of some data that suggested failures, there may be reasons for some hope here. The organization of this forum is that we're going to have four really internationally leading panelists here. They include Bill Robinson from Stanford, who's going to talk about the biology of osteoarthritis and how rheumatoid arthritis biologics might affect it. We'll have reviews of specific literature by Weiya Zhang, who has done a meta-analysis of this area, and by Margreet Kloppenburg and Philip Conaghan, who have both been leaders in carrying out clinical trials, testing particular agents that might work or might not work in osteoarthritis, with a summary of their literature. And then, as we found in the past one of these that was very successful, the discussion serves to be really a focal point for our learning and our ability to understand what might be going on here and whether there's promise and in what areas there's promise. So we hope to allow sufficient time for people to discuss this topic and raise questions that are of concern to them. I want to start, next slide, with a patient voice, who's, based on my conversations with her, a very articulate, thoughtful woman who has both rheumatoid arthritis and osteoarthritis, and is currently on successful treatment for her osteoarthritis, TNF inhibitor. And I wanted to ask her a little bit about how that's affected her RA, what joints are affected by that, and also how it's affected the knee osteoarthritis that she has. Laura, do you want to speak for a minute or two?
Sure. My name is Laura, and I am in the United States, just outside of Seattle, Washington. I've had RA since I was age 27, so I'm going to say it's definitely more than 20 years. My RA affects me mostly in my hands, my wrists, my ankles, and of course there's the fatigue component. And recently I was diagnosed with knee osteoarthritis, and I'm working to try to help that feel a little bit better so that I can get out and do the activities that I want to do.
Do you want to comment on, Laura tells me she recently went on golimumab or Simponi. Do you want to comment on the effect that's had on the wrist and ankle and foot symptoms, and also to give us some insights into what effects it's had on your knee osteoarthritis?
Sure. So as I've had my disease for quite a long time, I've been on a variety of biologics and have had to switch biologics because they have become ineffective. And the most recent one I started was the golimumab, which I know I'm not supposed to use the brand names, but anyway, forgive me if I'm mispronouncing that. But it has certainly helped my, my symptoms for my RA. My hands feel better, and usually for me, I can tell when I'm feeling a little bit better when I wake up in the morning and I don't immediately reach for my medications. When I'm feeling bad, that's the first thing I think about when I wake up. So I know that I'm doing better because, it's not the first thing that comes to mind upon waking in the morning, and my stiffness isn't lasting nearly as long as it has been in the past. However, for my knee osteoarthritis, in my particular case, it doesn't seem to really make a big difference for me. I'm treating my OA with Celebrex. I'm sorry, I forgot. I need to look at my celecoxib. Had to look at my cheat sheet. But that seems to help with regard to the osteoarthritis. But I do feel that the biologics, for me at least, are not particularly effective at dealing with the inflammation due to the OA.
Okay. Thank you, Laura. That was very helpful insights, and one that I think as we move forward, you'll recognize, and others will too, as fairly consistent with a lot of the data that's been generated from these trials. We look forward to your participating in the discussion later, along with other patient advocates who I know are on the call. Let's turn now to some of the scientists who we want to hear from. And let's start with Bill Robinson, who was an international leader in our understanding of the pathophysiology of the contribution of inflammation to osteoarthritic pain and the destruction of the joint that occurs as part of disease. Bill?
Yeah, thank you very much, David, for inviting me to participate. And thank you, Jason and the Arthritis Foundation for organizing, and for everybody for joining. Can people see my slides? Or my slide, cover slide? David asked me to speak about why RA biologics and steroids might work to decrease joint destruction or pain in OA. And I'm not sure I'm going to have anything completely revelational for you, but I'm going to present a perspective and some ideas to think about, and hopefully it'll stimulate some good discussion. So I have no disclosures. I'm going to start.
Bill, let me just interrupt. I don't know if nobody's seeing the slides. Jason, can you stick the slides up? We all see you, Bill, and that's quite fine.
Okay.
I'm not seeing your slides. There you go.
Let me try and flip again. Hold on a second here. Okay. Sorry.
Hi, Bill. I'm controlling your slides.
So okay.
Just let me know.
Oh, great. Sorry. I thought that was my screen. That's your screen. Great. If you could go to the next slide, I have no disclosures. And the next slide, I'm going to start by just telling you how David Felson's initial studies looking at synovitis on MRI imaging of OA really changed my perspective on OA, and I think also suggests that certain inflammatory pathways are clearly active and playing a role. And then it becomes a question about which ones map on to existing RA or other drugs. Next, I'm going to briefly talk about inflammatory and innate immune mechanisms in OA, so cytokines and chemokines, complement mast cells, just one slide on each one. I'm going to kind of touch base about the CANTOS trial, and then some thoughts regarding considerations regarding RA biologics. So next slide, please, Jason. So just this is work that I think David really started the field's recognition that many of our OA patients have synovitis when you image them with gadolinium on their MRI, or if you do the right MRI protocol to pick up that synovitis. For example, approximately 2/3 of generalized knee OA patients have synovitis or enhancement on GAD MRI, and it's associated with increased pain and with increased progression for cartilage loss and to joint replacement. So this really changed at least my perspective about OA, and I think shows that inflammation is likely playing a central role, and then it becomes how you effectively target that inflammation. Next slide, please, Jason. This is just another set of images showing different areas of the joint that are involved with this synovitis. Next slide, Jason. And just thinking about the different pathways that could be involved, everything from neuropeptides to DAMPs and cartilage breakdown products to macrophage and other innate immune cells like mast cells. In the next slide, Jason. And so we profiled cytokines in synovial fluids and serum samples from OA and RA. So on the left side is normal serum, moving towards the right, OA serum. And so there's slightly more heat there. And when we do statistical comparisons in people with more advanced OA, KL3 or 4, we get statistically significant increases in blood cytokines in those more severe patients. And then you can see OA synovial fluid in the green in the middle is hotter. And then, but it's still not nearly as kind of hot, meaning it doesn't have as many elevated cytokines as RA serum, which is even significantly hotter. And finally, RA synovial fluid on the far right, which is, you know, kind of full-blown inflammation. So what this slide basically shows is that there's elevations of multiple different cytokines and chemokines that are present in OA and predominantly in synovial fluid, but to a certain extent in more severe disease also detectable in the serum. And the next slide, please. That's just highlighting the OA synovial fluid and the OA serum. And this is a study that Carlos Scanzello did with Mary and Steve Goldring and Peggy Crow, showing that basically in people undergoing you know, meniscal tear surgery, that they had inflammation in their synovial lining and a pronounced chemokine signature in their synovial lining. And that was also associated with increased pain in these patients. Next slide, Jason. And this is a kind of additional cytokine profiling we did with Constance Chu, who's now at Stanford. And this basically shows that in synovial fluids, there's a mild increase in cytokines, perhaps in some people with ACL tears, 2 weeks to kind of 100 days out. In people with a degenerative meniscal tear, which is, you know, a precursor for OA, there's higher levels. And then you can see in radiographic OA the highest levels. So even at these early stages of, you know, post injury ACL tear, as well as in this pre-OA state degenerative meniscal tear, there's clearly ongoing low-grade inflammation in the joint. And some of these cytokines that are elevated are obviously the targets of some of our approved therapies for RA, or their receptors are. Next slide, Jason. And this just shows a chemokine. You know, we did a study in different chemokine and chemokine receptor knockout mice, and we showed a, you know, a potential role for CCL2 and CCR2 in this particular study, and others have shown other results for different chemokines. And likewise, Carla had that signature in the synovial lining for chemokines associated with pain and with OA in her meniscal tear study. Next slide, please. My lab has also been very interested in the complement pathway, and we showed that multiple arms of the complement pathway impact the development of OA, and that there's sublytic formation of the membrane attack complex, which is the terminal complement component, that may in part kill some cells in OA joints, but also triggers you know, sublytic inflammatory signaling in the cells and causes them to make MMPs and also certain cytokines. So we think the complement system, a key component of the innate immune system, which is being activated by cartilage breakdown products, is contributing. And then the next slide, just this past year, we also published that we believe mast cells play a critical role in the pathogenesis of OA. And there's, in our eLife paper that's cited there, we see actively degranulating mast cells in the synovial lining of human OA. And they're releasing tryptases and other mediators that we think are contributing to breakdown of the joint and inflammation. And the next slide. So recently, I think or over the last several years with the results of the CANTOS trial, where they tested canakinumab, which is an anti-IL-1 beta drug that Novartis has, and they were testing it for atherosclerosis in a very large trial. And in a kind of a secondary analysis, they came to appreciate that there was less patients with OA progressing to arthroplasty. And I think this hasn't been, this is the ACR abstract that's here, and it hasn't been formally published yet. And, I was discussing this with Nancy Lane and, trying to understand why this trial might be positive. So it's anti-IL-1 beta for OA. There's IL-1, anakinra was approved for RA in receptor antagonist that blocks both IL-1 and alpha and beta. But it really only prevented RA erosive progression and not so much RA pain. And we really don't use it clinically for RA. I treat a lot of RA patients in rheumatology clinic. And, I've never prescribed anakinra for a single RA patient, nor canakinumab. But I think the clinical trials suggest that it might have some activity, at least against erosive progression, not so much against synovitis and pain. And so anyways, they seem to see a quite significant effect in reducing arthroplasty in this trial. And, as Nancy provided, kind of important insights, at least to me, and kind of, there were several features of the patients in this trial and of this trial that might be associated with that. First, patients had a prior history of OA and an elevated CRP. So you might argue that they had a more severe form of OA and some active inflammation. And second, this trial was a very extended duration for kind of 3+ years to see this result. Because AbbVie had a different molecule where it was a bispecific antibody that one arm of the bispecific or part of the double-decker bus inhibited IL-1 alpha and the second IL-1 beta. And they ran several trials with that, but really didn't see much signal. And in that trial, patients did not necessarily have an elevated CRP. And they also ran the trial for a shorter period of time, and thus they didn't have that longer duration. And perhaps those are significant differences, in those results. So, and next is my final slide. Just some of the thoughts about RA biologics. I mean, I think that there's multiple reasons why you might have failure of a drug in an OA trial. So I'm going to list 3 here. The first is what I would term a primary failure. The target just isn't relevant in OA. So, you're targeting something perhaps in the story that Laura shared with us. Maybe it's targeting TNF, and I don't know if TNF's relevant or not. I mean, I think there's these studies where they inject TNF intra-articularly, and it seems to provide, some pain relief and other things. So, but one reason why your drug may not work in OA is just wrong target. The target's just irrelevant. A second reason is what I term technical failure. This is your molecule doesn't penetrate or get into the tissue. So a monoclonal antibody doesn't penetrate a non-inflamed joint. So if you look at the gradient of how much antibody gets in from the circulation from a peripherally dosed antibody into the joint, it's about 40% in a highly inflamed rheumatoid joint and dramatically less when you have a very low-grade inflamed OA joint. So many of the RA drugs may have failed just simply because they don't get into the joint where the disease process is ongoing. And the third major reason I list here is what I call tertiary failure. This is like a broken trial. You just wrong patient population, wrong design, etc. So in the case of the CANTOS trial, they obviously took people with more severe disease, with elevated CRP, so they had inflammation, and they ran it for a long time. And maybe that's what differentiates it over kind of the AbbVie molecule that was a shorter trial and not with that inflamed population. Those could be some of the key differences. So with that, I'll stop and happy to discuss at whatever point's appropriate, David.
Hi, David. I don't know if you're there or you're on mute.
Yes, thanks, Jason. Why don't we start now to look at some of the evidence that has evaluated RA biologics and their effect on OA, starting with Weiya, who is a world's leader in meta-analysis in this area, and has done some of the work that's helped us sort of summarize what these trials have shown.
Thank you very much, David. Can we all see my slides?
Looks
Yeah,
good.
looks great.
Right. First of all, it's very good to see you all in this way, really. Long time no see, David. Long time no see, Margaret and Phil. I noticed Ali Morbisheri is on the list. So hello to everyone. It's good to present some of our works in terms of meta-analysis of the current trials on conventional or also biological DMARDs. So some of our results may answer Bill's questions, some of them may not. So DMARDs is really being used heavily in inflammatory arthritis, mainly rheumatoid arthritis, and they've been classified as conventional and biologics. So conventional mainly methotrexate and hydroxychloroquine, and there are loads of biologics available at the market now, but we focus on those used in RA. Thanks to Bill for his very nice presentation in terms of inflammation in OA. So these slides actually show our previous work on the systematic review of ultrasound-detected inflammatory markers in synovial. So, as you can see from these slides, which include about 30 trials, 5,000 people, we can see for ultrasound-detected effusion, synovial hypertrophy, and Doppler signals. Very effective, very different between people with knee pain or knee OA compared with the general population. That is really the base we actually move on to see more in terms of inflammation in OA and also anti-inflammatory drugs. We did a systematic review, literature search, and meta-analysis using random effects model. These are PICOs, so we focus on people with symptomatic OA. We only look into DMARDs used in rheumatoid arthritis, and our comparator is placebo because we want to see whether DMARDs works for OA. And we only look into pain relief at the treatment peak time point, under the assumption if we cannot pick up any significant result at the peak time point, that means we cannot pick up at the other time point either. So we're only interested in the randomized controlled trials. We did the overall analysis for all DMARDs, and also we look into high quality of the trials, and also we subgroup them, look into different type of DMARDs, different targets of biologics. And we also look into subgroups according to joints, type of OA, and also publication type. All of these really using Hedges effect size and 95% confidence interval. We get into 5 databases, identify 90 RCTs, and another one from identified from other resources. And eventually we got 11 trials which met our inclusion criteria. 1,200 people involved in these 11 trials. 7 trials were published in full text, 4 only conference abstract, including Margreet's etanercept trial. By that time, we haven't got the full publication, but now it's available. And also fierce hydroxychloroquine trial, which was in abstract at that time point. And then in terms of DMARDs, 6 trials for conventional DMARDs and 5 trials for biologic DMARDs. Are they different in terms of the trials? So the distribution of this really show only 1 trial over here, which shows outlines. All others actually quite homogeneous according to Funnel plot. So this is a forest plot we have got, and we focus on the highest sort of pen reduction. The peak pen reduction varies from trial to trial, as you can see from there. And for biologics, as you can see, no better than placebo. More importantly, 5 trials for biologics, they are homogeneous. They pretty much like come from the same population. So the pooled effect size for pen relief is no better than placebo. So this is homogeneous. And then for conventional DMARDs, there are some sort of heterogeneity there. And pool them all together, again, no better than placebo. So, but because of one of the trial, JACAS trial, and which actually very high effect size over there, that influenced the result. If we get rid of that trial, and it will squeeze down the effect size even further. Overall, combine everybody together, and you could see that it's marginally significant, but the effect size is very small. It's been like a paracetamol effect size, which is not really clinically important according to NICE recommendations for a minimum clinically important difference, which is 0.5 times of the standardized deviation. So we then try to subgroup them and to look into those in good quality of trials where we focus on allocation concealment, because this is most important quality indicators for trials. We didn't find any better with DMARDs over placebo. And we subgroup them according to different type DMARDs, interleukin 1 inhibitors or anti-TNFs. Again, we didn't find any better than placebo. So by joint, separate analysis, look into knee or hand. We didn't have a hip trials, but these 2 joints again show negative effects, no better than placebo. Classified OA into erosive hand OA and non-erosive hand OA. Before we did this analysis, we thought it should be better than placebo in erosive, because this is inflammatory osteoarthritis, but we didn't pick up anything there either. Limitations of this meta-analysis. We include abstract, which is not based meta-analysis, because abstract only give you primary outcomes. That was one of the reasons we only got pen outcome from this meta-analysis. And abstract didn't provide sufficient information for us to really classify, look into quality of trials and so on. However, if we separate abstract and the full text, we didn't find any difference between these 2 really, and they all show no better than placebo. And another caveat of this meta-analysis is 11 trials really show high risk of bias, especially in terms of the selective outcome reporting. This is heavily influenced by the abstract. Time point, although we hypothesized if we cannot pick up the peak time point difference, we cannot pick up another, but that is not always the case. The best way is looking into area under the curve. For subgroup analysis, you can see from my previous report slides, they are very small sample size for each subgroup. That may influence the result. In conclusion, DMARDs at the moment have little or even no effects over placebo for OA pain. Further studies on inflammation and its roles in OA pain are needed before repurposing any existing anti-rheumatic agent. Finally, I would like to thank my colleagues, especially Monica Person, my PhD student, who lead on this, and any others who actually join me for this meta-analysis, and also future studies try to understand inflammation in the general population, which we are doing at the moment, and have some results we will probably discuss next time. Thank you.
Thank you, Weiya. That was a very nice summary of where we were, I think, a year or two ago. I'm not sure it included the CANTOS trial data, but it sounds like it included other very relevant data for us. Now, having said that, there's now new information. And among the new information pieces that I wanted to bring to bear on this question are work that's generated and been led by Doctors Kloppenburg and Conaghan. And I wanted to then let's turn to them and ask them to begin to provide additional information, which we'll try to summarize a little bit at the end. I hope we don't confuse people by overwhelming you with different pieces of heterogeneous data, but so far we've seen great promise biologically, but Weiya has shown us that the reality of the trials, at least through 2018, wasn't very promising. Let's then turn to Margreet to update the story a bit. So Jason, can you help us?
Good afternoon to everybody here from Europe. So it's even at the beginning of the evening here. Thank you very much for this invitation. I think about an exciting topic. I was asked to discuss with you data that we obtained with 2 trials, investigator-driven trials that we set up in a specific patient group, patients with inflammatory hand OA. And for some 15 years, we are working on that, and we are wondering whether inflammation in this specific patient group could be a target for treatment. These are my disclosures. And to give a little bit of background why we thought this is of interest, is that we know from clinical practice that patients can have inflammation in intervallar joint OA as part of their hand OA, and we did some studies with ultrasound and with MRI and with also other people in the field, and then we showed that there in many people is inflammation visible. However, it's also good to realize that people have many hand joints, and that's maybe in most patients only in a few hand joints per patient that you see this active inflammation that's going on. And furthermore, we thought this is clinically relevant because it is associated with pain, and we could show associations not only cross-sectionally, but also longitudinally, and also others did that. And we saw that there are associations with structural damage. And here you see some examples of MRI synovitis and structural damage that goes on over 2 years. So taking everything together, we thought this must be a potential target for treatment. Of course, at the end of the day, looking whether it's really a potential treatment target is whether we can really, when we treat people with anti-inflammatory drugs, see that they get less pain and less structural damage. Now, already Weiya showed us what are the data up till now, and there are many negative studies also in the field of hand osteoarthritis, but also there are some positive studies. And then we looked in more detail in these studies, and we thought that maybe there have been some limitations in the trials that have been performed so far. That could have to do with trial design. Some of these trials were rather small, or the dosage of the drugs that has been used, maybe 1 or 2 injections with biologics, so that's maybe also very difficult to obtain an effect. Inclusion criteria that sometimes not require certain pain levels, or that you have inflammation to start off with, and also outcome measures could be a limitation. So that was the reason that we set up in investigator-driven studies, 2 proof-of-concept studies, all in patients with hand osteoarthritis with inflammation. And the first was focused on with a specific target being tumor necrosis factor alpha with a TNF blocker, and the second one is with a more general anti-inflammatory drug being prednisolone. And in these trials, there are, of course, many details to share with you, but I will not do that due to time constraints, but will give a short overview of what are the most important points. Now, this is the first, the EHOA study, which looked in the efficacy of safety of 1-year treatment of etanercept. And this was a multi-center trial in 4 centers in Europe. And what we included in this specific patient group is patients with finger osteoarthritis that have to have signs with fits with erosive disease, because we were interested in structural change there as well. Patients really have to have pain that flared after NSAID washout, and we really want to make sure in a clinically way and in an objective way with ultrasound that there is inflammation present. And to be honest, this was not easy job to do. This was very tough. Here you see the trial design. Half of the patients get etanercept, the other half placebo. The primary endpoint was after 24 weeks, when patients had received 50 milligrams etanercept weekly, and thereafter the dose was tapered. We did a clinical assessment and some imaging assessment. Patients that were included were especially middle-aged women with a fairly amount of pain when they started in the study. However, I did not show that here, but I already pointed out that it was not easy to have all the inflammatory characteristics to be there, and 50% had no inflammatory signs in the way we had put it in our methods section. And then you can see here the results. This was the primary endpoint. That was the VAS finger pain after 24 weeks. And as you can see here, that's this part of the graph, there was some change in pain. Here, it's what you see here. However, and this was also better for the etanercept treated group. However, this was not statistically significant, and also after 1 year you saw some change, but this change is not statistically significant between the groups, and we saw no differences in secondary clinical outcomes. Because we realized that it is very difficult to get all these inflammatory characteristics in the included population, we already pre-specified a per protocol analysis in which patients really had to fulfill all the inflammatory characteristics. This was a smaller group, but here you see that then after 1 year, you see that there is a statistically significant difference in the pain people experience. We also did the per protocol structural damage analysis, which you see pointed out here, with a GUS score, and the GUS score looks at erosive evolution. You see that there is a difference between the group, and this difference means that there is more remodeling in those patients that receive etanercept. We also did a small sub-study using MRI. No difference was seen with synovitis on the MRI, but we saw that there was a difference in MRI bone marrow lesions between the 2 groups. Post hoc, we did some interaction analysis, and what we saw is that there are differences between the groups, what you can see here, but only in those joints that at baseline have signs of inflammation. Here we looked for the radiographic outcome, here we looked for the MRI outcome, but then we could show that there are differences. So what did we conclude from this study? In fact, it was a negative study because we did not reach the primary outcome. The VAS finger pain after 24 weeks, there etanercept was not superior to placebo. However, we could see that there were some improvements in the per protocol population with symptomatic and inflammatory completers. Then I will share with you the data of the second study. This is the HOPE study, and here we investigated efficacy and safety of 6 weeks treatment of prednisolone. It was also an investigator-initiated study of 14 weeks. You will recognize many of the inclusion criteria. However, here we did not require erosive disease to be present, but we also wanted here objective signs of inflammation. Here you see the study design. Half the patients got prednisolone during 6 weeks, and after that it was tapered, and the other half of the patient of the other arm received a placebo. The primary endpoint was after 6 weeks, and we followed patients for 14 weeks. Baseline characteristics show also here that the majority were females of middle age. And what you see here is that although patients were not selected on having erosive disease, that the majority had. This is the primary endpoint, the VAS finger pain. And as you can see, there was patients that received prednisolone had significantly less pain after 6 weeks, and the difference was 60.5 millimeters on a VAS scale of 0 to 100, and this is statistically significant differences. However, it's also good to realize that still in many of these patients there was pain. It was not all resolved. And we tapered the medication, and after tapering, the difference between the group disappeared. Here you see it pointed out in another way. We looked for the Omorakto-Warsa responder criteria, and there are significantly more patients that reach this responder criteria that used the prednisolone. Also were differences seen on the secondary endpoints, only not on grip strength. And of course, we were very interested whether we could also see a difference with imaging or more objective measures. And with ultrasonography, looking for synovial thickening, we saw at 6 weeks that there was a statistically significant difference between the groups. But also here, you see that after stopping the medication, the difference was gone. Maybe it's good to realize we did not see a difference with power Doppler signal. And we did also study these patients with MRI, but we could also not see a difference with MRIs for MRI synovitis, although we saw a difference also here with MRI bone marrow lesions scores. So we concluded that prednisolone is superior to placebo in painful hand OA with signs of inflammation. However, the effects disappear after tapering. And maybe in some patients during a flare, this could be a new treatment option for hand OA, although we think it's important that we should look for future studies for what's the optimal dosage, and also what we have to do with the duration of these treatments, especially because after tapering and stopping, the symptoms reappear. Taking everything together, I think I want to conclude that anti-inflammatory treatments affect symptoms and signs in patients with inflammatory hand OA. It could be that we in this way consider local inflammation as a target for treatment in symptomatic finger OA, but it's really important to see that when we start such a treatment, inflammation has to be present. There seems to be differences by different anti-inflammatory drugs. And it's also good to realize that pain improves with this anti-inflammatory treatment, but it does not disappear. And after discontinuation of the anti-inflammatory treatment, also the efficacy disappears. So I think still we need further research to understand the nature of inflammation of OA. That's how we started off, role of different cytokines, etc. And their mast cells maybe, so we really need more understanding. And of course, we also need to understand more which could be then effective anti-inflammatory medication for whom in which dosage. Thank you for your attention.
Thank you, Dr. Kloppenburg. Margreet, that was great. And a very concise and understandable summary of two important studies. So I think what we had was Weiya telling us that this approach really didn't work. And now Margreet telling us, well, maybe not so fast. And both with etanercept showing a little bit of an effect that didn't quite reach significance, and low-dose steroids clearly showing an effect. And then let's turn to Philip Conaghan. Dr. Conaghan has been involved in an important study that may provide us with a glimpse of where we might go. Margreet, I have you on the line, and I think we need to switch Jason to Philip.
So I'll share my screen now, David, if that works. Is that working?
Looks good.
Okay, thanks. So thanks to the Arthritis Foundation, Jason and David, for doing the work, getting us together today. It's quite nice to do this, as Margreet said earlier, from a distance. That's my disclosures, although nobody's doing enough research in this area. Companies, thank you. Now, there's been some mention earlier of osteoarthritis, essentially phenotypes. And it's worth thinking about what we think is going on in individual patients. And most importantly, I'm putting this up there so we think about, I guess, local and systemic factors at least. I'm more convinced that within a joint, say within knee OA, things are much the same across large cohorts, but I don't quite understand local and metabolic and systemic type factors. So I think there's a number of things we don't understand about osteoarthritis. And Bill's already touched on the importance of multiple pathways in this disease. And I just throw this up there since my focus is on interleukin-1, if you like, the first of the cytokine revolution over 30, 35 years ago now, since that data was published. And IL-1 beta the first, and we probably still know a bit more about IL-1 beta than IL-1 alpha, but the multiple pathways that these cytokines are key in cascading and starting. So I'm just going to briefly touch on some topics that have been covered again briefly by others, and touch on a few of the previous IL-1 trials. And one of the issues here is that if you look at, and sorry, I think one of my slides might have got lost, but I was going to say that the summation of where we were before was that there was a pathogenetic rationale for why we might want to treat somebody with an IL-1 antagonist. The animal model data is a bit mixed, and the summary is, how then does the human data summarize, and what does it look like? So of the 3 published trials we've got out there, this was an intra-articular recombinant IL-1 receptor antagonist, that Xavier Chevalier published years ago now. And it's a single injection with a primary outcome of WOMAC pain at 4 weeks. And you can see, although there might be a small signal at day 4, there wasn't a signal at 4 weeks after single injection. So that's one of our trials. Then we've got the AMG 108 trial, which is an IL-1 receptor 1 antibody, and both IL-1 alpha and beta bind to the IL-1R1 site. So this is blocking both. And if you look at panel A on the right on the slide, you'll see there at the 6-week primary endpoint, which is mean change in the WOMAC pain again. And this was a subcut drug, not an IA drug, but a subcut given every 2 weeks. Oh, sorry, every 4 weeks for this trial. Then you see there's a numeric improvement in pain at 6 weeks, but it's not a big improvement and it doesn't reach significance. It is interesting, and I included the CRP levels over time, which is showing something about target engagement of the IL-1 antibody, but no effect at 6 weeks with a subcut drug. Then we've got the lutikizumab, the AbbVie drug, which was an anti-IL-1 alpha and beta, and this was called Illustrate-K. And Margreet was involved with the Illustrate-H or HAND trial. And essentially, this is a typical phase 2 with multiple doses of the drug versus placebo, and a primary endpoint of WOMAC pain at week 16, and secondary endpoints of various structural things around inflammation. And for brevity today, I'm just showing the knee pain results, since the other studies I showed were knee pain studies. And I don't think we can also always lump hand and knee pain studies together. We've got to be careful about doing that. And what you see here is at the primary endpoint of 16 weeks, 1 dose of lutikizumab, the 100 milligram doses, reaches statistical significance, but not the other doses. And there's really no other sign. So this is a subcut, a systemic therapy given every 2 weeks with a 16-week endpoint, and probably not showing a lot on pain except for 1 dose. And I can summarize by saying the structure endpoints were not significant. So I think this summarizes, this is from a nice review Tonya Vincent presented last year, which says high plausible biological activity for this, for treating IL-1. The in vitro data good, the preclinical studies moderate, but the human clinical studies little based on the data that I've just shown you. So what's happened to change that relates to the canakinumab anti-inflammatory thrombosis outcome studies. Now, pretty obviously, this wasn't an OA trial. This was all about hearts and heart disease. And the main trial, canakinumab, if you're not familiar with it, monoclonal antibody to interleukin-1 beta. And the hypothesis here was that since inflammation drives atherosclerosis and atherothrombosis, that treating inflammation, even if you don't treat lipids, might improve outcomes. So it randomized a huge number of men and women who'd had a previous myocardial infarction and had an elevated, highly sensitive CRP. So very different for the OA trialists on board to the people we put into usual OA trials. And they got 3 doses of canakinumab subcutaneously every few months until they had achieved enough primary endpoints. And the primary endpoints were non-fatal MI or stroke or cardiovascular death. So that's what this trial was. It's a cardiovascular trial. And there's quite a lot on this slide, but I just want to show you this is the primary endpoint for the canakinumab 50, 150, and 300 milligram doses. And what you see in this trial, published in New England Journal by Paul Ridker in 2017, was the 150 milligram dose shows a significant benefit in terms of reduction in those primary endpoints, the non-fatal MIs in particular, over an average follow. The average follow ended up being 3.7 years. And again, just to show you as another endpoint here, that the HS-CRP was reduced in a dose-responsive way. So again, target engagement and clinical trial benefit for this cardiac population. So that's interesting enough, and I haven't shown other studies subsequently published which showed evidence of reduction in lung cancers and also in gout attacks throughout. But what's interesting here, a signal that was obvious out of the main trial adverse events was that you see that there was more infections, first of all, in the canakinumab treated group, and I've just pulled all these. This is the bit of the table about all doses. And you can see there's increased fatal infections in the canakinumab group, which is probably not surprising. The fatality might be surprising, but the increased infection rate, not so surprising. You're using something that affects innate immunity like an anti-IL-1. But also noticeable in this was a reduction in osteoarthritis adverse events. And on the basis of that, Novartis looked at a post hoc analysis of CANTOS, and Bill's referred to this abstract, which I can talk about today, which was presented at ACR in 2018, and the manuscript is under review at Annals of Internal Medicine now. And looking at total knee replacement and total hip replacement, OA adverse events at the entire cohort and those with a prior history of OA. So remember, it's not an OA trial, so you can only look at certain things. But noticeably, what it showed in terms of joint replacement outcomes, when you look at all the different combined canakinumab groups, which is the red arm here, and the placebo arm, you see quite a difference, up to a third reduction in joint replacements over the duration of this trial. So a very important observation in a non-OA study. Similarly, the effects for OA adverse events, and it's certainly not a very robust endpoint as people reporting their OA adverse events, but it's probably something about people coming, for those of you who do trials, saying my pain's worse in my right knee, my pain's worse here. And when you look at this, again, you see a reduction in these, and again, with the 150 and 300 milligram doses, the higher doses of canakinumab showing benefit. Sorry, I'm going in the wrong direction. And when we sum that up overall, you can see the adverse events in all patients versus the signal in people who had a primary OA, peripheral OA history, that you see the same signals there in these groups of people. And I'll say again, remember, this was not a OA trial. So to finish on this, I think the big message out of CANTOS is we have to rethink the role of IL-1 inhibition in OA. Bill's already touched on differences for trials generally and for previous trials here. I think we've got to think of inclusion criteria, especially the fact that this was recruited for HS-CRP. This was a much more massive trial than the 80 or so patients per arm in the couple of reasonable sized previous IL-1 trials, and we followed them for a lot longer period of time. So both the previous large trials were done with subcutaneous or systemic delivery rather than IA, and were short outcomes. Remember, week 6 and week 16 endpoints on pain. I think this is telling us something else about pain and structure. We've got to be very careful thinking that structure and pain is just about synovitis. It's locally, it's a lot more than that. And I think we have to think about local and systemic effects of inflammation on pain, because this is, remember, a systemic therapy in CANTOS. And I am assuming, and again, it's an assumption, that people had less joint replacements because they had less pain. And that's up for grabs and discussion. So I'll finish there, David. Thank you. Back to you.
Thanks for Philip for adding to this series of terrific presentations. And I would like now to open to the discussion. I've got a couple of chat discussions on already. Not surprisingly, let's. I've got the two very prominent people in this field, Ali Mobasheri and Jeff Katz. Ali, you were first. If you're still on, do you want to? This was after Bill's presentation and raised the question of if the drug can't get in. Do you want to go ahead and express this question? Say, unmute yourself and go ahead and ask.
Thank you very much, David. Yes, I think my question was regarding whether it's intra-articular or whether it's subdermal. And of course, Bill made a very nice point about primary, secondary, and tertiary reasons why some of those early trials might not have worked. But really, my point is about if the problem is in one or a couple of joints, why would we take the systemic approach instead of intra-articular injection? That's really my key point.
I'm open to. I think the people to address that are people who thought a little bit about hand versus knee stuff, and also Bill, who raised this question initially. Let me, Bill, do you want to take a stab at responding, and then I'll open it up to the other panelists too.
I mean, I agree that systemic therapy where you can treat effectively multiple joints, has a lot of advantages in most patients. But clearly trauma is a major risk factor. And so if you have a single joint that's involved due to trauma, then perhaps, I think a systemic therapy would be best, but it's obviously trickier because I think the biologics are failing in part because they just don't get in to the joint.
Okay. Philip or Margreet, do you want to try to respond to the question that Ali raised about systemic versus perhaps intra-articular therapy?
So I think Bill's point is well made about access. My concern has been, so I think it goes in a number of ways. How much pain is local, how much is systemic and needs greater drug exposure. How much does get into the joint from systemic absorption is really interesting, and how much may cross blood-brain barrier is really interesting too, I think, for the systemic side. I think there's arguments, one of the strong arguments I've always wanted a systemic therapy for is that most people have pain in more than one joint. And most of the knee pain people have hand pain and back pain and other things. So I think in some ways a systemic therapy would be desirable for us. But the proof of the pudding and whether it's getting into joints needs some proof. And we need to see that, and we need to know that this is an effect that's happening locally or systemically on pain. And again, I'm guessing the pain. Margreet.
No, I agree with you, Phil. I think that it would be, of course, nice if we could, when there is just one joint what is painful and is affected by OA, that we could inject it locally and treat it locally. However, we know that often many joints are painful. On the other hand, I also think that we don't know at the same time, or now when there are several joints painful at the same time, whether the process that gives the pain in these different joints, although the patient have it at the same time, have the same underlying mechanism or process. That's what you see when you think about hand OA, where you have a lot of joints, of course, that can be affected. But when you do ultrasonography, you see that there are only a few joints where really inflammation is there, although it could be that there are more joints painful at that time. So even when you then give a systemic treatment, you don't know whether that will be effective in all the painful joints, or maybe only in those joints that have at that moment inflammation. So these are the things that maybe also make that when you, for instance, have an outcome measure that is rather global, that these outcome measures are at the end then negative and leaving you with a negative trial, although in some joints really there has been a positive effect, but we can find that.
Okay, thanks. Let me turn to Jeff, who asked some additional questions about the CANTOS trial, which, let me remind people, was not an intra-articular trial. It was a systemic trial that had apparently intra-articular or pain-related effects. But having said that, as an introduction, let me turn to Jeff, Jeff, if you would unmute and go ahead and pose your question about the CANTOS trial.
Yeah, I guess my question starts from the observation that the active group had about a 20% lower risk of cardiovascular events, which themselves might contraindicate a knee replacement. So there's an alternative explanation, which is that, you know, therapy was successful in enabling candidates for knee replacement to go ahead and have their knee replacement rather than, you know, to have to sit it out. So with that, you know, as background, and with the prior studies that showed no effect of IL-1 on pain or structure, I just wonder whether in this, you know, well-funded trial they gathered something like an SF-36 or some functional status measure not intended perhaps to capture knee pain, but which might be used to look at, you know, difficulty doing stairs or things like that that might give a little bit more clinical validity to this conclusion. Knee replacement is a really tricky outcome to study, as I think, you know, many of us have discussed on many occasions, and this seems like another slippery situation where it could potentially be unrelated to the target that we're, or the pathway that we're talking about here.
I'll defer to Philip. Philip, do you want to address that?
I think there was not, Jeff, it would have been lovely to have an SF-36 or something in there, but that was not available. Remember, this was a cardiology trial and their outcomes are very different to our trials. So we don't have that in there to tease it out, Jeff. I think the only thing, this effect, if I remember correctly, and I'd have to see the analysis, was not just, so one interesting point you raised was this effect only in people who got well enough to have an operation. And I don't think that was there, but that's something that we probably need to look at because that's something that would be interesting. Although the difference being so large, I'd be a little surprised, but worth looking at.
There's an additional question, one that's focused on Margreet. Chris Liddell, if you want to unmute and ask your question, but let me combine that. So you're asking about biochemical markers, and I guess I would, in posing your question, also bring up the possibility that the CRP elevation that was a criterion for eligibility in the CANTOS trial, which is the one big positive trial here, you know, we maybe ought to be asking that question too. Do you want to add to what I just said, Chris? You still on? Do you want to unmute yourself? Okay, well, I don't hear anything, but let me raise that to the panel, which is, you know, another peculiarity from our perspective as an OA trial of the CANTOS trial was this CRP requirement, the CRP elevation requirement. Okay, should we be doing trials restricted to CRP elevated patients? Should we be doing stratified randomization so we can figure out if CRP or other biochemical markers are ones that allow us to determine whether there's an effect in certain people. And I would recall Margreet's comments about inflammation in the joints, perhaps identifying people who are likely to respond. I defer to the panel. I don't mean to take the conversation away.
I don't think we know, David, but it is a fascinating question. And it cuts to the old arguments about metabolic type OA and those things that we often wondered about, what's the association. So I wondered, do we have some sort of sensitization process going on in people who are in that metabolic category? And that's the group we managed to treat. But that's pure speculation, not provable yet. It would be good to analyze some old data sets. I'm going back to my methotrexate OA trial to try and have a look and see what a HSCRP does. So it'd be good to analyze old data sets and also to think about it at least as some sort of sub-analysis in studies being planned now.
Right. Other comments from the panel? Margreet, do you have anything to add here?
Yeah, no, I agree. But it's also good to, I'm always trying, when you think about this CRP, that's of course you measure something that you measure that systemically, and then you're always wondering where is the source of the inflammation that leads to this CRP. And when I think about hand OA, that's even what we know from rheumatoid arthritis, when you have only a few very small hand joints that are inflamed, yes, I can imagine that you don't find CRP even there. So we have to do studies, I think, to see whether CRP can help us out. For knees, of course, that maybe can be different. That these are large joints, but I have no experience with that. But it would be very helpful if it if we could do, yeah, it would be nice. But up to now, I think we need more data.
Okay. Chris is now able to unmute. Do you want to add anything to the conversation or ask a question, Chris?
Yeah, no, can you hear me?
Yeah.
David, and especially Margreet, but it's also related to the presentation of Phil that we have seen. One of the things that struck me in the publication of the Cantos trials was they were selecting patients on the basis of high HS-CRP. So a certain stratification, although a completely different patient population, not an OA population. The question for me is mainly to Margreet, especially if we talk about erosive hand OA, if you can use certain biochemical markers to stratify the patients and get maybe a better idea. Maybe you have already looked in this, Margreet.
No, we didn't look at it at that way. No. So that's a very interesting suggestion. On the other hand, now it's something we could do. It's but we don't have the answer. No, when we didn't do it.
Yeah, but I was more thinking in the direction, Margreet. You know me. Maybe there are some samples around, and you can look in the samples and look in this. A little bit like we have done in the Czech cohort, but especially for this hand OA and erosive hand OA, certain maybe not general inflammation markers, but more what I normally call the tissue inflammation markers would be very helpful to identify maybe a subgroup that is very low in your trials. Of course, maybe we end up with I don't know, 10 people or 15, 20, what have you. But it would be worth to have a look, since in all what we have heard in the talks today, we have heard a lot about what I normally call, and I permit myself to call it, an all-comer population. We have a KL grade, we have a certain ORSCAN, we have a certain inflammation determined by the physician, but we have not looked in subpopulation very clearly, apart from the Novartis trial. The Novartis trial was already stratified for high HS-CRP, so high inflammation. And that was for me a kind of a signal that maybe we should have a look further in this, especially if we talk about anti-inflammatory and mainly in RA used drugs. They are anti-inflammatory, but maybe they are useful in OA situations where we have severe inflammation ongoing.
No, thank you very much for this suggestion. From the HOPE study, we have samples, so we can do that.
Sounds good. Let me turn a little bit to Bill Robinson to ask him a question. I'm intrigued. Let me start by saying Weiya did a lovely job of reminding us that most of these studies have been null, including a lot of IL-1 studies, and a lot of the conversation of the presenters was about whether results reach significance. I think Margreet, for the first time, began to give us a sense that even etanercept and many of these treatments don't have big effects, but they seem to have small effects. Okay, and then the steroid trial that Margreet talked about, that has a big effect. Okay, and you'll notice that the difference between the steroid group and the placebo group was very large. Margreet made the point thoughtfully that a lot of people still had a little bit of pain, but the reduction in pain was really quite substantial compared to placebo. And then the IL-1 CANTOS trial showed a 50% or nearly 50% reduction in knee and hip replacements. But what I wanted to do was go back to the steroid trial for a minute and say, does the efficacy of prednisone or prednisolone in improving symptoms in hand osteoarthritis and transiently also in knee osteoarthritis, does that provide us with any clues as to which cytokine or set of cytokines we ought to be targeting? Are we targeting the right ones? Are there others we ought to be considering based on effects that steroids have? Bill, do you have any insights there or thoughts?
I mean, I think that if, you know, I always think of rheumatoid and psoriasis and Crohn's as like the house being on fire with flames coming out of the roof. You put that out with a fire hose and water. And I'm not sure OA is that type of fire. Maybe it's an innate immune fire that's won't respond to a water-based fire extinguisher or a TNF or, you know, perhaps an IL-1 per the discussion a couple minutes ago. So I don't know, maybe we need to target different pathways.
Are there pathways that you would suggest given effects of, let's assume for the sake of argument that Margreet's trial provides us with an example of something that really works well.
Well, I mean, I think steroids are much more penetrating than a biologic therapeutic. Etanercept really doesn't get in substantial amounts into the joint. So it's fabulous if there's a little signal, but like it's hard to interpret that result because, you know, I don't think the drug has gotten where it needs to really go to know if TNF is a relevant target or not in OA.
Okay.
I would argue that. I mean, I think the steroid's penetrating more and you see this effect, but you know, steroids like turtle wax, you know, it hits everything. So.
Okay. Let me ask Philip a different question from CANTOS, which is, how long will it take, Philip? When did we start to see in the CANTOS trial, was it so long that the other trials failed because they just didn't study people long enough? And does that provide us with guidance as to what we need to do? Are we going to have to tell our patients, you know, you're not going to feel anything for quite a while? It's going to take a long time for you to be able to notice that this is working for you?
So the separation in the CANTOS trial, and I best be careful about this without the data in front of me, but my memory is the separation is about 90 days or so. So I don't think it's dreadful, David. I don't think it was a year to see the signal. And that would be important, I think, for patients. Although I've long believed that the problem for osteoarthritis and the so-called holy grail search for a D-mode is based on exactly the DMARD principle, which was probably the wrong paradigm for us to have. And an osteoporosis paradigm would have been much better. Years of cumulative injury before you get to a clinical endpoint. And I think that would have changed our thinking about what we did in OA trials. And I think patients will take bisphosphonates or drugs that have no obvious benefit for them. Now, I know compliance isn't great, and we can have a compliance chat about that, but people will take drugs to prevent something bad happening. So I think if we had clear evidence, a lot of people would. But yes, you'd have to give them a realistic time frame. You're going to have to take this for at least 3 to 6 months before you notice a benefit. And I think many people would do that just on joint replacement benefit alone. But I do take Jeff Katz's point. Joint replacement is not a straightforward outcome.
No.
Let me open to the audience for questions if you have them, and also the panelists if you'd like to pose questions to someone else on the panel, that'd be great. We can, if you want to unmute yourself, that's fine. You can also put something in the chat and we'll call on you.
David, may I ask Bill Robinson a question, please?
Sure.
Hi, Bill. Really interested in your data about mast cells. Could you please comment on the possible interactions between the mast cells, the observations that you've made, and possible interactions between them and the macrophages? Perhaps the mast cells are interacting with the macrophages, altering their biology. Could you comment on that, please?
Yeah, I mean, I think that, first of all, mast cells are not rare in OA tissues. I mean, you don't have to scan the slide to find them. You turn on a high power field and there will be mast cells on view. When we do single cell RNA-seq, it's about 3% of cells that make it out that are live mast cells. I think that they're probably more like 5 or 7%, and that we're killing a few. And when we do the digestion to get the cells out of the synovium, so they are there. We show in that paper that I cited, you know, they're actively degranulating in the synovium. Others have we see correlations, and others have described correlations of various mast cell release factors like tryptase with OA pain. We show that they, degrade proteoglycans and activate chondrocyte apoptosis. I think they're definitely interacting with multiple other cells, everything from neuronal input and neuropeptides to, mast cells, like every immune cell, they integrate different signals, and frequently it takes more than one signal to activate you as an immune cell. And so they're basically taking in signals from all these other mediators, whether they're DAMPs and neuronal inputs and chemokines, and that's activating the mast cell to be kind of chronically activated. So, and mast cells are very different than many other cells. They constantly recharge their granules. It's not like a neutrophil netting where it's a one-shot deal and you're done. Mast cells recharge their granules and can degranulate, and then can form the membrane back up, make their, synthesize their granules again and re-degranulate. So mast cells are resident cells for life in a tissue. And I think, our data suggests that they're, I always thought of mast cells as like all or nothing, like you anaphylax or you don't. But I think there's these states of kind of chronic low-grade activation where they're kind of degranulating. It's the same thing for complement. I used to think of complement as all or none. You either activated complement, you lysed a cell. But our data for complement in OA is the same thing. There's this low-grade level of activation. It's not fully activated, blowing away all the chondrocytes and the synoviocytes. It's sublytically forming and causing inflammation that way. And I think mast cells are degranulating the same type of way. And those are obviously all innate immune pathways, which are different. They're interrelated with adaptive immune ones, but they're, an arm of the immune system, obviously. And I think it'd be great to see more drugs that target those pathways being characterized in our trials in OA.
Another part of this, David, if I may, another part of this inflammation, so when we're just talking local and synovial inflammation, I still think of synovitis as likely differing along the 30-40 year course of disease, that the drivers may well differ from that first meniscal tear inflammation to the person. And I think of there's a seminal, what I think is a really important German paper from a few years back, where they showed with X-ray diffraction that 100% of post-mortem knee specimens, OA knee specimens, had crystals embedded in the cartilage. And you just have to think, what's happening later in the phenotype that might be driving inflammation that's different from earlier in the phenotype? And I've never thought of a way to explore that or look at that. But given that much of our synovial histology comes from joint replacement synovium, when there's plenty around to play with, we'd have to think that that may all be based on a sort of late disease mentality.
Let me, we have a bunch of patients in the audience, and we've gotten one important question from Patrice Johnson. Patrice, if you want to unmute yourself. I think, let me just introduce for a minute the idea, a larger idea that Patrice is raising, which is, okay, you guys have been talking in a very focused fashion, okay, about RA drugs that we might use for OA, and it's been very interesting, but what can I do, that's not getting a knee replacement that's promising in addition to those? Patrice, do you want to unmute yourself and tell us a little bit about you and what question you have?
Hi, everybody. I am a patient. I'm also a volunteer with the Arthritis Foundation. Thank you so much for addressing my question. So my journey with osteoarthritis began when I was diagnosed with OA at the age of 30. When I was 12 and 13 years old, I had two traumatic injuries followed by 2 surgeries. So back then, if you want to think back 35 years ago, there weren't very many options for treatment for OA, short of a knee replacement, which at the time I refused to do. So I do have a fairly active lifestyle at this point, but as I age, I'm now 65, and so I'm looking, I can control the pain, yes, with over-the-counter medications and braces, but I'm wondering, looking towards the future, and I know nobody can predict the future, but is there anything that's going to be coming out soon with, short of what I said, the knee replacement or drugs? Thank you.
I'll open that up to the panel. Anybody want to, the rheumatology group, make some, respond to Patrice in a way that might be helpful to her, thinking about potential treatment she might try?
So Patrice, some general statements first. I spend much of my time as an academic talking about pharmacological therapies for OA. I spend my entire time in the clinic as a rheumatologist teaching people to do quadriceps strengthening exercises for their knee OA, since it's by far the most effective and safe therapy we have. And most people I see still cannot do a proper straight leg raise. It's really hard to have strong quadriceps that's the big thigh muscle, if you've got a slight bend in your knee. And many people, especially like yourself, who are getting on to later structural damage, often have a fixed bend in their knee. And you may be able to walk 5 miles, but that doesn't mean you've got strong quadriceps muscle. So I absolutely, first thing would say to you, strong quads is God. It's really what it's about, and strong muscles are important everywhere to reduce joint pain. In terms of other therapies coming, I don't think for the non-pharmacological therapies, there's a lot coming that aren't what you know of already. And as I say, strong muscles is probably the biggest core of that. For the drug things coming, you may know, and that may be the topic of other meetings from Arthritis Foundation, there are things like monoclonal antibodies to nerve growth factor that may get to market. It's interesting that drugs looking at peripheral pain mechanisms rather than anti-inflammatory mechanisms look like some may get to market. So there may be some new drugs. We haven't had new drugs in 100 years. So things actually haven't changed from when you had your first things 30, 35 years ago. Treatments are pretty much the same as we had 30, 35 years ago. Some oral NSAIDs, maybe a little bit of opioid and occasional intra-articular steroid. Things haven't changed on the drug front, but they may be about to change with some new pain mechanism-based drugs coming.
So I guess as a rheumatologist who sees a lot of patients with osteoarthritis, Patrice, I don't necessarily agree with everything Philip said. I studied to some extent biomechanical therapies for osteoarthritis, and I agree entirely with him that we're sitting here talking about drugs, but what we do in clinic is often try to improve the biomechanics of the knee. There is a promising therapy that I don't have any commercial involvement with called APOS therapy, which I would suggest you look into, which educates the muscles of the lower limb to walk on a different part of the knee, it looks like, and has been found in one large trial to be highly effective. And then I would also suggest, if you're miserable, that you think about nerve blocks that go to the knee, which have been now studied in a couple of different trials and are available often through anesthesia departments that ablate for a prolonged period of time the nerves that cause the pain in the knee, and are widely available through a variety of patented approaches and non-patented approaches by pain doctors and anesthesiologists, and that's also reasonable. So I think while we're having discussions about the biologic therapies, and I agree very much with Philip that anti-NGF treatments are also very promising, this is actually a potential golden age for people who want to avoid getting knee replacements. I think one part of that golden age is what we've been talking about, but anti-NGF therapies are very important. And I think biomechanical therapies are going to be part of this picture too. And there's going to be novel approaches there that include not just shoes that alter biomechanics, but built-in reminders of ways to walk and strengthen that because of wearable technologies have become available to us in ways that they weren't 10 years ago. With it remind us to walk in a certain way. When we don't walk right, we get a little buzz, things like that. I think they're all being tested, and I think many of them are very promising. So I think the answer is yes, there's a lot of promise here. Did you have other questions? I'm not sure. It depends on where you are in the United States or elsewhere in the world and what opportunities and referrals you might get, but I think there are opportunities there. I think also the Arthritis Foundation is going to be sponsoring another one of these fora on what I would call dicier treatments, stem cell treatments, platelet-rich plasma treatments. And I think many of us in the academic community are a little bit skeptical of those treatments, but they might hold promise. I'd be happy for other panelists to comment on them too.
Thank you.
David, could I add on something for Patrice's question?
Sure.
Yeah, it's Weiya Zhang here. Patrice, can I ask you, because you've got quite a long time knee osteoarthritis for 35 years, can I ask you, do you have any, in addition to knee pain, do you have any other pains on the other side of your joint?
I do have RA as well, and I am currently on steroids for that. The knee pain, how to describe this? Sometimes it is in one area of my knee, and other times it is all over in my knee. I also have a Baker's cyst that I developed last year on the back of my knee. Currently, it is now smaller than it was. And I did not receive any treatment for that. It just kind of decreased in size on its own. And currently it is not painful.
Right. How about your sleep? Do you sleep well?
No, I have insomnia.
Okay. So what sort of exercise you are on at the moment, or you prefer?
I walk 4 to 5 miles a day, and in the summer I add in swimming. But of course, I live in the United States, California, And of course, swimming pools are all closed right now, so because of COVID.
Right.
Yeah, because you have got this sort of multiple conditions in addition to OA, and your
Yes.
sleep is so. Current research we have done is really compare different exercises. It seems to me aerobic exercise, you're walking quite a lot,
Yes.
and that would be fine. So, and our recent research also show for the later stage of OA and with multimorbidities. So Tai Chi or mind body exercise is quite useful. So depends on which outcome you're looking for. If you're looking for pain relief, Tai Chi seems to be on the top. So or any other like yogos. So a mind body exercise is very effective for pain. Certainly talking about functions and other outcomes, maybe strengthening, like Phil said, strengthening of your quadricep strength, which would be more effective. I think this coming up more and more now. We get into different type of exercise and tailored with different sort of patients with different comorbidities and also main outcomes.
Thank you.
Yeah, that was very helpful. Thanks, Weiya. I would also advertise the Arthritis Foundation's last forum on osteoarthritis, Patrice, which was about exercise and strengthening and what might work. Because I think Weiya's very thoughtful in terms of evidence-based practice and evidence supporting and not supporting particular approaches. But you could hear a lot of the experts in the area speak to which types of exercise might be most effective in that earlier forum. Let me also turn to Guy, who's one of the Arthritis Foundation sponsors here, who also had a question. Guy, do you want to unmute yourself?
Sure. So thank you. This has just been fascinating to listen to from all the presenters and panel. Prior to coming to the Arthritis Foundation, I was involved in macular degeneration, and there in that field we had bevacizumab, which was a large monoclonal antibody that there's a very long story around it, but ultimately it was engineered into a smaller molecule, just the FAB region of the antibody, which became ranibizumab. And the goal of that was creating something of about a third of the weight that could potentially pass through the blood retina barrier. And as we talk about, as Bill mentioned, some of the sort of the primary difficulties, or I forget how he framed it, but of gaining access to the non-inflamed joint, I'm wondering if that type of approach might have some bearing here in the context of osteoarthritis.
So what is that an antibody to, Guy? Do you know?
VEGF in this case. It's to decrease proliferation of blood vessels in the eye, but it's modeled off of Avastin, which is a colorectal therapy. So that the nuances of that particular molecule are, I don't know how appropriate they are to discuss, but the overarching issue here is that they had a molecule that, like I said, longer story, but they believed that there would be difficulty getting it across the blood retina barrier. So the desire was to take its binding affinity, preserve that binding affinity, and reduce it to an overall smaller molecule. And they were successful from an engineering standpoint in doing that, and you all can read up on the longer history of that. But the fact of the matter is they were able to create, and this is Genentech, was able to create something that was about a third of the mass and was able to pass relatively freely across a very restrictive barrier.
To Bill, which is, in a situation like this, would VEGF inhibition be one of the things you might consider in targeting the inflammation in OA, there clearly is an enhancement of vascularity in the synovium, a modest enhancement of vascularity in the synovium. And the synovium in a lot of studies now looks like it's very strongly associated with the pain of osteoarthritis. Is this a reasonable target?
We ran various kinase inhibitors through the various OA models, and we definitely have positive, we've published on several of the different, sets of results looking at VEGF and stuff. I think the issue is that systemically there's potentially a lot of off-target, on-target unwanted tox in the long run, because I think of OA as a disease that you need to treat for literally decades. So, I think, to Ian's point that I think that this is the type of strategy, making an FAB out of other antibodies that are against the right target. Like if TNF were a suitable target, or IL-1, it would give you much more penetration, and maybe you could, get more activity out of, an FAB of canakinumab or of, a TNF. So, I think it is a promising approach, but, particularly for certain things, I think the safety, I think it has to be pretty squeaky clean in the long run for the general OA population.
And that makes sense. I appreciate the comment. The direction wasn't necessarily to ask if VEGF is an appropriate target, but the overall engineering and design approach might be applied to another drug, like you mentioned canakinumab. So, but the caveats seem well thought. So I appreciate the response.
Okay. Well, I'm not seeing any additional questions in the chat. Why don't we give it a minute or so, and also people can unmute themselves if they want to ask a question or get involved in the discussion. So Jason and Guy, why don't I turn this back over to you?
I think you're on mute, Jason, still.
You there, Jason? So I want to thank the panelists for doing a terrific job of helping us understand where we are in terms of the data supporting biologics in OA and what that promise might be, which I think is substantial. And we have one person who wants to ask a general question. Why don't you unmute yourself, and then we'll continue. Hazem Abed El Aziz. Okay. Well, is there any algorithm for walking in OA? Do you want to, let me defer a little bit to the rheumatologists who deal a lot with OA patients. Are there particular instructions or suggestions that you give to your patients with OA that with respect to walking or exercise in general? Philip or Margreet or Bill, you want to take a stab at that?
My general rule is first get strong and then increase your walking. So I see people who use their legs as stilts, and that's always a good sign that you've got weak leg muscles. If you can't get out of a deep chair easily, or you can't get out of a car easily, or find that when you get up first thing in the morning, you're using your legs as stilts to get around, that's a pretty good sign you've got weak leg muscles. So I think if you start there, do some basic quadriceps work, see a physiotherapist to work on that, and then you can start to increase your sort of walking distance and rate. So do it in steps, but get strong first.
Other comments or thoughts? Okay, let me finish up here, I think. with once again a thanks to all the panelists who did a wonderful job, and to the Arthritis Foundation for sponsoring this. I think I can say confidently that this is also going to be the discussion and the talks are also going to be available on the Arthritis Foundation website, and that will be broadcast by email and other methods so that people can access this.